Imagine going to the doctor because you're experiencing like excruciating pelvic pain, or maybe even sudden unexplained panic attacks.
Right, which is terrifying.
Yeah, completely. And the doctor tells you it's happening because your elbows bend backward.
It sounds, honestly, it sounds like science fiction.
It really does. But today, we are exploring a medical reality that is just fascinating. So if you are someone who is double jointed or, casually described as bendy, you might have been told your whole life that it's just a quirky party trick.
Oh, absolutely. A parlor trick.
Right. Or maybe you've been dealing with a weak pelvic floor and you've just accepted it as like a normal part of life. Well, welcome to today's deep dive. Our mission today is to answer a really highly specific question. Can hypermobility affect vaginal sensation as well as support?
And it's a phenomenal question. The answer is a resounding, complicated yes.
Yeah.
Because being bendy, it fundamentally changes the structural architecture of the pelvis. But, it doesn't stop there. It literally changes the way the brain maps internal sensations.
Which is wild. And we are pulling from a really compelling stack of medical literature today. We've got clinical data, specialized physical therapy guides focusing on Ehlers-Danlos syndrome, which you'll hear us refer to as EDS.
Yes, and hypermobility spectrum disorders, or HSD, as well as pelvic floor dysfunction.
Exactly. Okay, let's unpack this because
Okay.
I think we need to start with the literal foundation. Like when we talk about someone with hypermobility, what is actually happening at a microscopic level in their connective tissue?
So to really grasp this, we have to completely reevaluate how we picture the pelvic floor. Most people hear that term and they immediately visualize, like, a hammock of muscle.
Right, that's the classic image.
Yeah, and muscles are a massive part of it, absolutely. But the pelvic floor is actually this highly complex web that relies heavily on connective tissue.
Not just muscle.
Right. We are talking about fascia and ligaments,
Yeah.
specifically structures like the uterosacral ligaments, and they act as a supportive, passive scaffold.
Passive meaning they don't contract, they just hold things.
Exactly. Their entire job is to literally suspend the pelvic organs in place from the bones of the pelvis.
So they are like the cables holding up the bladder, the uterus, the rectum.
Precisely that. Now, in conditions like EDS and HSD, the body's collagen is structurally different.
And collagen is basically the glue, right?
Yeah. You can think of collagen as the glue that holds the human body together. It's in our skin, our joints, our organs. But in hypermobile individuals, this collagen is formulated differently.
How so?
Well, it is far more elastic and significantly less resilient. It stretches, but it doesn't always bounce back.
Okay, I was trying to visualize this earlier. Tell me if this analogy works. It's like building a massive suspension bridge. But instead of using thick, rigid steel cables to hold up the road, you've used bungee cords.
I love that.
And over time, just under the everyday weight of gravity and traffic, that bridge is inevitably going to sag.
That is a brilliant way to picture it, honestly, because the passive support system is fundamentally compromised. Those bungee cords are too stretchy, so the pelvic organs just don't have the baseline stability they require.
Wow.
And this structural difference leads directly to a vastly higher risk of pelvic organ prolapse, often referred to as POP.
Right, POP. And that's the clinical term for when the organs actually begin to descend, like essentially falling down and pressing into the vaginal or rectal walls.
Yes. And we really need to translate what that mechanical failure feels like for you listening. Because in daily life, prolapse often manifests as a profound sensation of pelvic heaviness or like a dragging pressure.
I've heard patients describe feeling like their insides are literally coming down.
Yeah, or falling out. And sometimes, it becomes noticeable when a tampon suddenly won't stay in place anymore or it sits at an uncomfortable angle.
Right. And the medical literature breaks this down into specific architectural failures, right?
Yeah.
Because it's not just one type of sagging. Depending on which bungee cords give out, you get different types of prolapse.
Exactly.
Like a cystocele is when the bladder drops forward into the front wall of the vagina. A rectocele is the rectum bulging forward into the bat wall. And then uterine prolapse, where the uterus descends straight down the vaginal canal.
Yeah, and what makes this so crucial for hypermobile individuals is that these structural failures can show up much, much earlier in life.
Oh, really? Like how early?
We are talking about people in their 20s or 30s experiencing these symptoms, completely absent of the classic risk factors, like multiple vaginal childbirths or advanced age.
Because their structural integrity was inherently different from day one. I mean, their bridge was built with bungee cords.
Exactly.
But here is the causal link that really threw me for a loop. If the bungee cords are sagging, the body doesn't just give up and let the bridge collapse. it actually has a defense mechanism.
It does, yeah.
Which brings us to this massive counterintuitive paradox. Logically, if I know someone has stretchy, lax joints and stretchy ligaments, I'm going to assume their pelvic floor muscles are also loose, just weak, floppy, failing to hold things up.
Right, and that is the most common assumption out there. And it's an assumption made by a lot of medical professionals, too. But the reality is almost always the exact opposite.
Really?
Yeah, the pelvic floor in a hypermobile person frequently becomes intensely hypertonic.
Meaning overactive, like a constant muscle spasm.
Yes, exactly. It's a state of constant, unrelenting gripping. Because the ligaments are failing to provide that passive background stability, your nervous system essentially goes into a state of panic.
Oh, wow.
The brain senses the vulnerability, it feels the instability of the pelvic joints and the organs shifting around, so it forces the pelvic floor muscles to step in and act as full-time stabilizers.
It's overcompensating.
Totally overcompensating.
Yeah.
The muscles begin to guard, they clench up tightly to manufacture a sense of safety and control that the faulty connective tissue simply cannot provide.
Wait, hold on. I have to push back on this because this completely contradicts standard medical advice.
Oh, I know.
I mean, every single women's health pamphlet, every magazine article on the planet says Kegels are the holy grail for prolapse and pelvic floor issues.
Yeah, they do.
So are you saying a doctor who tells a hypermobile patient complaining of pelvic heaviness to just do your Kegels is giving bad advice?
I am saying that for a hypermobile patient with a hypertonic pelvic floor, standard Kegels can be actively harmful.
Actively harmful. Wow.
Yes, this is a critical misunderstanding in generalized care. If your muscles are locked in a 247 spasm trying to act as bungee cords, they are exhausted.
They're running a marathon just while you're sitting at your desk.
Exactly. They are fatigued, filled with lactic acid, and desperately overworked. If you introduce Kegel exercises, which are entirely focused on forcefully contracting and tightening the muscle, you're asking a muscle that is already clenched at 100% capacity to clench harder.
Oh, that sounds awful.
It actively worsens the problem. This can lead to severe urinary urgency, where you suddenly feel like you have to pee right this second. It causes incomplete bowel emptying because the muscles are literally too tight to open and release.
And pain, I imagine.
Huge amounts of chronic pelvic pain. The muscles literally lose their mechanical ability to relax and coordinate a normal contraction.
So if the answer isn't strengthening the muscle with Kegels, what is the intervention?
Well, the priority intervention is a clinical process called downtraining.
Downtraining.
Yeah, it's not about strength at all. It's about learning how to consciously identify that constant background tension, physically release it, and restore coordination. You actually have to teach the nervous system that it is safe to let go of the guarding mechanism.
That is incredibly counterintuitive, but it makes perfect sense when you map out the mechanics. But okay, here's where it gets really interesting. If these muscles are locked in a 247 spasm, trying to act as bungee cords,
Right.
what does that actually do to the sensory experience of the pelvis? Because it can't feel normal. Which pivots us right into the second half of our core question today. Sensation.
Sensation in a hypermobile body is a deeply complex landscape. Let's start by looking at a neurological concept called proprioception.
Okay, proprioception.
Yeah, proprioception is basically the brain's 3D internal map of the body. It's your ability to sense exactly where your limbs and muscles are in space without having to visually look at them.
It's the reason you can close your eyes and perfectly touch your finger to your nose.
Exactly. Now, in individuals with EDS and HSD, proprioception is notoriously impaired. The stretchy collagen receptors send fuzzy, really inaccurate signals to the brain.
You know, there was an anecdote in the clinical literature that brought this to life perfectly.
The biofeedback one?
Yes. A physical therapy patient was hooked up to a biofeedback machine. And for those who don't know, this involves small sensors placed on or inside the pelvic floor that connect to a computer monitor, showing a live graph of how hard your muscles are working.
Right.
And this patient apparently burst out laughing during the session because the line on the monitor was spiking off the charts, indicating a massive, intense pelvic floor contraction. But she literally could not feel it happening.
Completely blind to it.
Yeah. Her brain was completely blind to the fact that her muscles were screaming.
It highlights a profound neurological disconnect. Because the brain's map of the pelvic floor is skewed, you might be carrying immense painful tension, but your brain registers the area as relaxed.
That's wild.
Or conversely, you might intentionally try to contract the muscle and nothing happens because the neural pathway coordination is just lost in the static.
And beyond that neurological blindness, there is a physical reality to the lack of sensation, too. The literature points out that vaginal laxity itself, like the physical stretching and widening of the connective tissue inside the vaginal canal, can drastically reduce physical sensation and physical satisfaction during intercourse.
Yes, that is very common.
But then you turn the page in the research and you see the absolute opposite extreme. It's not just a lack of sensation or numbness, it's the presence of extreme, devastating, unwanted sensation.
You're talking about the pain data, and the statistics here are genuinely sobering. When you look at surveys of women diagnosed with EDS or HSD, roughly 64% report experiencing dyspareunia.
Let me stop you there. Dyspareunia is the clinical term for deep, painful sexual intercourse, correct?
That's right. It's pain that occurs during or immediately after penetration, and 64% is a staggering number compared to the general population.
Truly.
Furthermore, the data shows that about 50% of these individuals screen positive for probable vulvodynia.
And vulvodynia is chronic pain, usually described as like a burning or raw sensation on the external genital area, the vulva.
Yes. And to put that 50% into perspective, vulvodynia affects maybe 8 to 15% of the general non-hypermobile population.
Oh, wow. So that's a huge jump.
Huge. We are looking at a massive systemic increase in chronic pelvic pain for anyone with these connective tissue differences.
But I want to know the why. Like, how is this pain actually happening physiologically? If the tissue is just stretchy, why does it burn? Where is that pain signal originating?
A huge portion of it leads right back to that hypertonic guarding muscle state we discussed, and how those tightly clenched muscles interact with the nerves trapped inside them. We need to talk about the pudendal nerve.
The pudendal nerve.
Yep.
The clinical text described its path through the human pelvis as tortuous.
Very tortuous, yes.
It weaves a very complex, winding route through a dense landscape of muscles, bones, and ligaments.
It arises from the sacrum, right at the base of your spine, and it divides into several branches that supply the primary sensation to the majority of the pelvic floor, the perineum, the genitals, and the rectum.
Okay, got it.
Now, I want you to picture those pelvic floor muscles that are constantly gripping to try and stabilize the loose joints.
Okay, I'm picturing it.
There is a specific deep muscle called the obturator internus. It's this large, fan-shaped muscle that literally wraps right around the inside of your pelvic bowl.
Okay.
The pudendal nerve runs right alongside and through the fascia of this muscle. When the obturator internus and its neighbors are locked in a state of chronic spasm, they physically compress and crush the pudendal nerve.
Oh, so it's literally like stepping heavily on a garden hose. The flow gets blocked and the pressure builds up.
That's a perfect visualization. This mechanical compression causes a condition called pudendal neuralgia. Neuralgia means nerve pain, and it manifests as sharp, shooting, stabbing, or intense electrical burning pain anywhere along the distribution of that nerve.
That sounds horrific.
It is. For a patient, this can mean excruciating clitoral pain, deep rectal pain, or just unexplainable vaginal burning.
But here's the piece of the puzzle that is so crucial because it explains the craziest part of the whole hypermobility experience. The pudendal nerve doesn't just have sensory fibers that tell your brain, ouch. It also contains autonomic fibers.
It does.
Can you break down why that is such a big deal?
Because this is where we connect the pelvis to the entire systemic nervous system. The autonomic nervous system is the autopilot of your body.
Right.
It controls all your involuntary functions, your heart rate, your digestion, and critically, your sympathetic fight or flight response.
Wait, so the specific nerve in the pelvis gets crushed or irritated by tight muscles? It doesn't just cause localized pain. It can actually trigger a full-body autonomic reaction.
Yes. It creates a sympathetic nervous system upregulation. The physical irritation of the pudendal nerve sends a frantic signal up the spinal cord to the amygdala, the fear center of the brain.
Oh my.
It's essentially screaming, we are in extreme, immediate danger, even if you are just sitting calmly on your couch reading a book.
Which perfectly explains the clinical data. The literature notes that these patients will often experience sudden, terrifying spikes in their heart rate, unexplainable full-body sweating, pupil dilation, and intense feelings of agitation, doom, or anxiety, right alongside a spike in their pelvic pain.
Exactly. The physiological crosstalk is happening at a subconscious level. The brain interprets nerve compression as an existential threat.
I want to pause right here and speak directly to you listening. If you have ever experienced this, If you've had a sudden wave of severe anxiety, a racing heart, or cold sweats that somehow seem tied to a weird flare-up of pelvic discomfort or pain,
Yeah.
you are not going crazy.
Absolutely not.
It is not all in your head. It is a direct, documented physiological response to autonomic nerve irritation in your pelvis.
Providing that validation to patients is life-changing. Way too often, hypermobile individuals are told they're simply prone to panic attacks. They get referred to psychiatry, prescribed anti-anxiety medications, when the actual physical root cause is a musculoskeletal compression of a pelvic nerve, all because it's trying to compensate for stretchy collagen.
Okay, so we've established the mechanisms. Hypermobility fundamentally alters the support of the pelvis, causing the bungee cords to sag and leading to prolapse.
Right.
And it radically alters sensation, leading to a spectrum that ranges from proprioceptive numbness to severe autonomic triggering nerve pain. Knowing all of this, how do we practically navigate this in the real world?
That's the big question.
Because our bodies don't exist in a vacuum, right? They go through major life transitions. The medical data specifically highlights perimenopause and menopause as a critical danger zone.
Mm.
Why does aging make the bungee cords fail faster?
Well, life transitions that involve massive hormonal shifts act as the ultimate stress test for hypermobile connective tissue. Let's look at the mechanics of menopause. Estrogen is an incredibly vital hormone for maintaining the health, elasticity, and strength of all connective tissues.
Okay.
The pelvic floor and the vaginal canal are packed with estrogen receptors. They rely on that hormone to keep blood flowing and to keep the tissue plump and resilient.
So when estrogen levels naturally begin to drop and eventually flatline during menopause, the connective tissues are essentially starved. They
Exactly.
become thinner, more brittle, and even more vulnerable.
That's exactly it. The loss of estrogen strips away whatever remaining baseline resilience those tissues had. So a prolapse that was maybe incredibly mild or something a hypermobile person barely even noticed in their 30s can suddenly become highly symptomatic and physically disruptive in their late 40s or 50s.
Which sounds terrifying, honestly. But the literature is very clear that there are highly effective, practical interventions. One of the most consistently evidence-based treatments mentioned in the clinical guidelines is vaginal estrogen.
Yes, very effective.
But a lot of people hear the word estrogen and immediately panic about the risks associated with systemic hormone replacement therapy, or HRT.
Mm.
How does the clinical guidance navigate that fear for these patients?
It's a really vital distinction to make. Vaginal estrogen, which typically comes as a topical cream, a tiny tablet you insert, or a flexible ring, is highly localized.
Meaning it stays put.
Right. It directly treats the tissues of the vagina, the urethra, and the pelvic floor, plumping them up, restoring blood flow, and maintaining their structural health. Crucially, it has negligible absorption into the rest of the bloodstream.
So it bypasses the liver and doesn't circulate through the whole body.
Right. It entirely avoids the systemic risks that some people, or their doctors, worry about with standard oral or transdermal HRT. It is a phenomenal, low-risk preventative tool and a daily management strategy for hypermobile patients entering perimenopause.
Okay, let's talk about another practical tool the clinical data brings up for dealing with the lack of support, like the actual prolapse issue. Pessaries.
Ah,
I
yes.
think a lot of people don't fully understand what these are. Can you explain how they work mechanically in a bendy body?
A pessary is a removable medical device, usually made of soft medical-grade silicone. They come in dozens of shapes and sizes, and they are custom-fitted by specialists and inserted into the vagina, much like a menstrual cup.
Oh, okay.
You can think of it as internal physical scaffolding.
Like putting a temporary solid steel beam under our sagging suspension bridge.
Yes, exactly. It physically props up the descended organs, holding the bladder, the uterus, or the rectum exactly where they belong. By providing that artificial, reliable stability, it takes the strain completely off the exhausted pelvic floor muscles.
So the muscles can finally stop guarding.
Yes. Suddenly, the muscles realize they don't have to guard so fiercely. The nervous system calms down. This can significantly reduce nerve pain and drastically improve structural symptoms like urinary leakage or that dragging heaviness. It's an excellent, empowering, non-surgical option that patients can usually manage themselves at home.
You mentioned non-surgical, which brings us to a massive point of contention. A lot of people suffering from severe prolapse or chronic nerve pain might just want to be put under anesthesia for a quick fix.
Naturally.
They think, just operate, sew it up, and put everything back where it belongs. But the clinical guidance regarding surgery for EDS and HSD patients comes with a huge, flashing warning label. Why is surgery so risky here?
For patients with connective tissue disorders, surgery really must be considered a last resort. You have
Mhm.
to remember the fundamental microscopic issue we discussed at the beginning. The tissue itself is fragile.
The collagen is faulty everywhere.
Right, so if a highly skilled surgeon goes in to repair a prolapse, they have to use sutures to anchor the organs back into place, but they are trying to anchor those tight sutures into connective tissue that is inherently wet and stretchy.
Oh, I see.
It is mechanically akin to trying to sew heavy fabric using wet tissue paper as your base.
Oh, yikes. The stitches are just going to tear right through the paper the second there's any tension.
Sadly, yes. The complication rates are higher, the tissue healing is poorer and slower, and the failure rates, meaning the prolapse just happens again within a few months or years, are significantly elevated compared to the non-hypermobile population.
Which explains why specialized physical therapy is heavily emphasized across all the literature as the absolute gold standard of care.
Definitely.
But, as we established earlier, this isn't about doing sets of Kegels. What does specialized PT actually look like for someone with a hypermobile pelvis?
It requires working with a physical therapist who deeply understands the systemic nature of hypermobility. The focus is heavily on biofeedback, using those monitors to retrain that impaired proprioception, helping the brain literally see and eventually feel what the muscles are doing so the patient can learn to consciously relax them.
In the breathing techniques, the literature talked a lot about diaphragmatic breathing.
Yes, that's crucial. Your diaphragm and your pelvic floor act like a piston system. When you breathe in deeply, the diaphragm lowers and pushes your abdominal organs down onto your pelvic floor.
Right.
A specialized PT will teach you how to manage this intra-abdominal pressure so you aren't constantly bearing down and pushing your own organs further into prolapse every time you cough, lift something, or even just breathe heavily.
And they also look way beyond the pelvis, right? They zoom out.
Absolutely. The pelvis doesn't float in space. It is anchored by the joints of the hips and the lower back. If your hips are hypermobile and wobbling around, your pelvic floor will constantly spasm to try and hold your hips together.
Oh, that makes sense.
So a good PT will work on strengthening the external rotators of the hip, the glutes, and the deep core. By providing true, strong muscular stability in the surrounding joints, you allow the pelvic floor to finally feel safe enough to relax.
So let's synthesize this whole deep dive. We set out to answer a very specific question. Does hypermobility affect vaginal sensation as well as support? The medical reality is a resounding, vastly complicated yes.
It really is.
On the support side, stretchy collagen means the pelvic organs lack a stable foundation, leading to laxity, sagging, and prolapse. And on the sensation side, the body's desperate attempt to fix that instability creates hypertonic, exhausted muscles that can either completely numb your internal mapping or worse, mechanically compress the pudendal nerve, causing severe pain and even tricking your brain into triggering a full-blown autonomic fight-or-flight panic attack.
The interconnectedness of human anatomy is truly remarkable. A microscopic protein variation in your collagen cascades into joint instability, muscle spasms, nerve compression, and systemic anxiety.
So, for you listening, if you have bendy joints and you've been dealing with unexplained pelvic heaviness, pain during intimacy, urinary issues, or weird pelvic anxiety, you are not imagining the connection. Your body is functioning exactly how we would expect a hypermobile body to function under the laws of physics and physiology.
Exactly.
And it means that generic, blanket, medical advice, like just do more Kegels, might need to be thrown entirely out the window in favor of specialized care.
It really highlights why individualized medicine is so crucial. But, if we pull back even further, looking at that autonomic nerve connection we discussed, it raises an incredibly important question, something to really mull over. If our connective tissue dictates so much of our interoception, our brain's ability to accurately feel and interpret our own internal bodily states, how many people out there are currently in therapy, treating what they believe is purely psychological anxiety when what they're actually experiencing is a hypermobile body desperately trying to find physical stability in the dark? Think about that the next time you feel an unexplained physical tension creeping into your chest or your pelvis.
That is a profound thought to leave on. Because if your muscles are secretly fighting a 2147 war just to keep your skeleton together, of course your brain feels anxious. Thank you so much for joining us on this deep dive. Keep questioning the amazing, sometimes incredibly messy mechanics of the human body. And remember, when you step into the complex world of pelvic health, sometimes the easy answers are wrong, and you just have to look a little deeper at how the whole machine is built. Until next time.